안녕하세요. 나녹스 주주, 녹스지킴이입니다. 채널 방문해주셔서 감사합니다. 구독과 좋아요 부탁드립니다. 오늘은 나녹스 디지털 토모신텐시스에 대해 알아보겠습니다. 나녹스의 디지털 토모신텐시스는 X선 영상을 사용하여 3차원 이미지를 만드는 방법입니다. 이 기술은 디지털 방식으로 X선을 촬영하여 매우 얇은 단면 영상을 여러 장 생성한 다음 이를 컴퓨터 소프트웨어를 사용하여 3D 이미지로 복원합니다. 이러한 방식으로 나녹스의 디지털 토모신텐시스는 기존의 2D X선 영상보다 더욱 세밀하고 정확한 정보를 제공할 수 있습니다. 이는 암 진단 및 스크리닝과 같은 의료 진단 분야에서 매우 유용하며 특히 유방암 스크리닝 검사에서 효과적으로 활용될 수 있습니다. 나녹스의 디지털 토모신텐시스는 기존의 CT나 MRI 등의 이미지 검사보다 비용이 적게 들어가고 빠르게 검사를 진행할 수 있다는 장점이 있습니다. 또한 검사 과정에서 사용되는 X선의 양을 감소시키기 때문에 환자의 방사선 노출량을 줄일 수 있습니다. 최근 BVGH에서 발표한 샤브신 박사는 MSK 디지털 토모신텐시스에 대해 설명하고 있습니다. 해당 영상을 유튜브 자동자막 생성 파일과 함께 첨부하겠습니다.
Good afternoon and good evening. Thank you for joining BioVentures for Global Health's Introduction to Diagnostic Imaging Lecture Series 1. The primary focus of this lecture series is to strengthen capacities in diagnostic performance and image interpretation across the most common diagnostic imaging pathways. In this series, we'll be addressing various topics in ultrasound, X-ray, CT, and tomosynthesis. Here's today's agenda. Today's trainer is Dr. Shabshin of Penn Medicine, and she is head of tomosynthesis of Nanox. Today's lecture topic is musculoskeletal tomosynthesis, and following our lecture, we will have our Q&A session to round out our time. Please submit your questions in the Q&A box at the bottom of your Zoom screen. And as always, please introduce yourselves in the chat. Now I'd like to introduce and welcome Dr. Shabshin. Thank you.
Hello, everyone. I'm very happy to be here. And let me just share my screen really quickly. Just a second. Okay. Okay, can everybody see me?
I can see it. Thank you. Looks
Okay.
great.
Today, we're going to talk about tomosynthesis and its applications in musculoskeletal imaging. My screen, okay. And this is my short bio. I work in Israel and also at Penn, and I'm consulting to startup companies. I studied medicine, and also I have an MBA from Kellogg, and I'm very happy to be here. In general, about tomosynthesis, most of you have heard about digital tomosynthesis in the setting of breast imaging. This is already the standard of care in breast imaging. But in the other systems, in the other radiological applications are already out there, and you can see that there's literature, but there's not enough information for the societies to come up with guidelines and appropriateness criteria. But there are several FDA-approved machines that are standing in Europe and also in the US, and actually there are several also in Israel. and they're starting to gain popularity, and you can see that by the number of publications in the literature. So you've heard about how tomosynthesis works, but for the ones who were not present in the prior lecture, very shortly, as you can see, that there's an X-ray tube that moves and stops and then takes a shot. It moves and stops and takes a shot of X-rays. And there's a detector that can basically acquire, the data. And after that, all those images are combined to produce basically something that looks a little bit like X-ray in different layers in the body. What are the current uses and the clinical value of tomosynthesis? Well, in the literature, you will find papers about chest imaging, MSK, a few about abdominal, sinuses, dental, emergency medicine, and even papers about guidance for breast biopsies. And why is there a value to tomosynthesis? Because basically what it does, it declutters all those structures that in a radiograph are superimposed on each other, and it splits the radiographs to layer from either anterior to posterior or from one side to the other. It depends on the plane. And when we unclutter and separate these overlying structures, we can reduce false positives that are created because of that superimposition of structures, and we can also see some findings that were actually obscured by those overlying structures. We can characterize findings better, and also tomosynthesis helps us to understand better, to see better the anatomic location of findings. For example, if a lesion, for example, in the lung is on the skin or in the rib or in the lung, in the anterior lung, posterior lung, and I'm sure you've heard about that in the prior lecture. But today, we're going to focus on the musculoskeletal system. First of all, let's see how to read a tomosynthesis study. Now I'm going to switch to another screen. And just let me know, can you see the hands?
No, not yet.
Okay, so just a second. I'm gonna stop my, it worked for us before, Carly, but now it didn't, so I'm gonna share my screen again. Okay. Can you see the hands now? Yeah.
Yes, I can.
So this is an example of a conventional radiograph, and this is an example of a tomosynthesis study. When you look at the tomosynthesis study, it looks like a really bad quality radiograph, right? Because all of this is blurred, almost like the patient was moving or something like that. In the post of the radiograph, where everything has kind of the same sharpness. However, that's because when you read the tomosynthesis, you see we start from the skin, and whatever's in the plane of focus will be sharp, and whatever is out of the plane of focus, because it's not in that layer, is going to look blurred. So, for example, now I know that I'm in the volar aspect of the hand. Why? Because I look at the pisiform bone, right? And we can all feel the pisiform bone. It's in the palmar side of the palmar or volar side of the hand, and it is now sharp. But these structures are more dorsal, and that's why they are blurred. So when we read a tomosynthesis study, we only look at the sharp structures, right? So in this one, for example, I'm going to look at the pisiform, and the hook of the hamate looks amazing, but the body of the hamate is blurred because it's out of focus. It's out of the plane of focus. In this plan, I can also see a part of the first carpal joint. I can see pretty nicely a part of the metacarpophalangeal joint, and some of the fingers. So for example, if I want to evaluate now the pisiform, I'll go back and forth, I'll scroll back and forth until I'm sure it's blurred now, and now it's blurred at the other end, so I know I've finished looking at the entire pisiform. And if I want to look now at the triquetrum, then I'm going to go back and forth until I see from blurred to blurred, I know I covered everything. Okay, look, for example, at the ulnar styloid. Ulnar styloid is dorsal. So now I know I'm in a dorsal image. And when it will become blurred, I will know here, for example, here, I know I'm moving towards the volar aspect, and boom, I hit that triquetrum and the pisiform. This is how this is how basically we can scroll through a tomosynthesis study. So look, for example, at this area here. Again, I'm just going to show you that nice example of the superimposition of the pisiform on the triquetrum, right? And in this area, I see both bones superimposed on each other, but I can completely separate these two bones and evaluate each one of them separately without the superimposition of the other one when I read a tomosynthesis. Okay? Look at, for example, look at the bases of the metacarpals. And again, there is superimposition of parts of the bones on some carpal bones, and when I scroll through this area, you can see on every image, you can see another part of the bases of the metacarpals sharp, and other parts that are blurred because they're out of the frame of focus. Okay, so let's continue now. I'm going to go back to my slideshow. Can you see my slideshow?
Yes.
Okay, good. So basically, in the MSK system, it's good for evaluation of occult bone fractures. These are fractures that can be missed on radiographs. That's why they're called radiographically occult fractures. But sometimes, based on publications, we can see these fractures better with tomosynthesis. Again, because of the unfluttering of the structure of the bones. Sometimes we have doubtful findings. We're not sure whether this is a fracture or not, it's an erosion or not, and then we can, the tomosynthesis can be helpful as well. And it's good for both, also, in addition to fractures, it's good for inflammatory arthritis and degenerative disease. And it has been shown in some studies that potentially it can reduce the use of CT because, for example, if someone is not sure whether there's a fracture or not on radiographs and they do a tomosynthesis and they can see the fracture, well, maybe there's no need for CT. And again, I'm saying maybe because although there are some publications, there are no big data about the use. So let's look at this example. This is taken, as you can see, from an article. And look at the X-ray. Do you see anything where the arrow is pointing? I'm trying to focus you on specific areas of the radiograph, and just look at it for a second. Think to yourself whether you see something or not. And now I'm going to move to the tomosynthesis. Do you see the fracture now? This is the fracture. Okay, but did you see on the radiographs, if you even saw the fracture here, okay, did you see that there is another fracture in the radial styloid? It's impossible to see it even retrospectively. So on the tomosynthesis, we see these two fractures very clearly. It's very easy to see them. And even retrospectively, these fractures are missed on radiographs. Just think of the setting of a busy ER. Even when you calmly look at this image, it's hard to see the fracture. It's actually impossible. But just think of the setting when there's a lot of stress and everyone's busy and we work fast. How easier it is to depict these fractures. And this is another example. And here you can see this overlaying structure, right? Could this be a fracture or not? Clinically, the mechanism of fall in the outstretched hand, maybe there's a fracture. So maybe, if you pay attention to it, you can see that maybe this is actually continuous with the radius, but sometimes it's not that obvious, and also it was not obvious to whoever wrote this paper and also to the reviewers of that paper. But you can see here that there's actually a fracture in the tomosynthesis, but this line here was a superimposed line, and there is that fracture. Okay? And another example, what do you see on this image? And now let's look at the tomosynthesis. There is a common unit, distal radius fracture with an intra-articular extension. So yes, you can see that maybe there is a fracture here. You can think that maybe there is a discontinuity of the cortex here, but you don't have any doubts when you look at the tomosynthesis that there is a fracture. There is also a transverse plane that maybe you could see here with this tiny discontinuity of the cortex. Here you can see the line very clearly and the discontinuity of the cortex, and you can see the intra-articular extension. And another example of a toe injury, these are the radiographs. Can you see a fracture in the radiographs? Maybe. And this is the tomosynthesis, and clearly this fracture is seen. So retrospectively, yes, you can see something here. One could think that maybe it's a nutrient canal in the bone, or whether, I'm sure many radiologists, many very good radiologists would miss this if this is one of 100 radiographs they're seeing, consecutive radiographs that they're reading. And now let's move on to the pelvis. So let's look at how to read a tomosynthesis of the pelvis. And again, this is a conventional radiograph, and this is a tomosynthesis radiograph. So we know that here we have those sacroiliac joints, and they have this 3D configuration. We can see sometimes the anterior part, the posterior part, but it's very hard to see both parts of the joint. And also there's that superimposed gas in the bowel, which really obscures the left joint, and here parts of the right joint. We know that we have some posterior, the posterior column, we have the anterior column. In this area, they're superimposed on each other, and so and so. Now let's look at the tomosynthesis. So when we look at the sacroiliac joints, right, we can go from, let's see, where are we anterior and where posterior. So I'm going to look for the pubis symphysis, wherever it's sharp. And here the pubis symphysis is sharp. I know that I'm anterior, right? Because the pubis symphysis is an anterior structure. At this level, the humeral heads look horrible. They're so blurred, and the joint in general, and the spine, because the spine is posterior. So now I'm going to start scrolling and move to the back, and on each and every image, something else is going to start showing up as sharp, because it's getting into the plane of focus. So now I can see the femoral heads very nicely. I can see the bony trabecula, and go through the superior pubic ramus and from one blurred side to the other. So I know I covered it. And now I go to the ischial tuberosities. They're more posterior, so now they're sharp. When I look at the sacroiliac joints on each and every image, another part of the joint is sharp and the others are blurred. And you can actually see that there is a lumbosacral transitional vertebra articulating with the sacrum. And yes, retrospectively you can see it, but it may be hard to see because you have other lines that are actually coming from the bowel. So this line could also be coming from the bowel, right? So this is how tomosynthesis helps us to identify the different structures and to evaluate them in a more reliable way. And I have a question for you. Look at this image here on the right, on the left. I'm sorry, the 2D, the radiograph. And actually, I'm going to help you. And look only at this area here. Do you see a sclerotic lesion anywhere here? I believe all of you that looked at it they do not see a sclerotic lesion here. When I will scroll through this tomosynthesis, look at this sclerotic lesion. See? This is actually missed on the radiographs. Okay? Why? Because specifically in this area here, you can see it maybe, but specifically in this area, there are multiple parts of the bones that are superimposed on it, and therefore a sclerotic lesion was missed. And by the way, when we look at the spine, again, you can evaluate the facet joints, for example, here, and the pars interarticularis without anything superimposed on it. This is where we can see spondylolysis, pars defect, right? So we can actually separate that from the rest of the vertebra. And now let's move on. Go back to our slideshow. So again, this is all from the literature, and we are all aware of this significant problem of fractures, proximal femoral fractures in the elderly population around the age of 70 and up, but we often see it before the age of 70. Due to a simple fall, patients can fracture the proximal femur, and if there is no displacement, this can be very hard to see. And this is why, for the clinicians, even if they get a negative radiograph, but clinically they do suspect that there is a fracture, they have to relate to it as there's an occult fracture, that there is a fracture that was just not seen on the radiographs. In the first 72 hours, bone scintigraphy is going to be negative, and therefore this doesn't help. CT can see these fractures, but actually, and I'll show you in the next slide, there have been 2 publications in the New England Journal of Medicine that showed that MRI would be the most sensitive modality to show non-displaced fractures in the elderly, and therefore, if plain radiographs are negative, they actually recommend to get an MRI. However, although these papers were written 20 years ago, it's really not practical to just take all of these patients to the MRI. CT is more sensitive than the radiographs, but again, some of these fractures can be occult on CT as well. So let's look at an example. Again, this is from a published article by Asimov, and he showed, he or she, I'm not sure, this is a radiograph of an elderly patient with a fall. And can anyone see a fracture here? I think it's really almost impossible. A, B, but there's another line here and there's another line there. There are also, again, sometimes it's just like skin folds and just folds in the clothes or blanket or a bed sheet. But when we look at an image taken from a tomosynthesis study, it is very clear that this is a fracture, a non-displaced fracture. And again, these are the papers from the New England that showed that not only there's increased sensitivity for detection of those fractures, but actually sometimes the MRI changed the type of fracture from a non-surgical one to a surgical one. What about inflammatory arthritis and spondyloarthropathies? So for rheumatological patients, this can also be more sensitive and more specific than radiographs. And when I'm saying more sensitive is because, for example, it can show sacroiliitis that is missed on radiographs. And why is it missed? On one hand, this can be created by gas biol when there's actually no sacroiliitis. On the other hand, when we see this, we're not sure whether this is real or this is gas biol. But when we declutter the images and we see the sacroiliac joints without any superimposed gas biol and without any superimposed other parts of the joint and the bones, then we can see that there are real erosions here. I mean, this is actually a grade 3 sacroiliitis. And this is another example. In this patient, you would say that maybe there's mild sacroiliitis here and moderate on this side, but when you look at the tomosynthesis, this is pretty severe. Look, it involves a large portion of the joint, and actually this one is also worse than it looked like on the radiographs. And what about arthritis? So as you can see, this is a radiograph, this is a tomosynthesis, and this is a CT. So what can we see on the radiographs? We can see maybe some small erosions here. When we look at the tomosynthesis, we can see a pretty large erosions, and several of them, right? I mean, on every image, we see other parts of the erosion. This is a big erosion, more than initially we could evaluate on the radiographs. And when you look at this CT, the size and the number of erosions are actually comparable. There was a paper that even showed that the performance of tomosynthesis was actually pretty close to MRI, and we know that MRI is the most sensitive imaging modality for arthritis, for erosions. This is an example of a thoracic spine. You see the patient is severely kyphotic and osteoporotic, and we can see a fracture here on the radiographs, but when we look at the tomosynthesis, we can see that this is not the only fractured vertebra. There are other wedged vertebra, additional ones, that are very hard and actually impossible to appreciate on this 2D radiograph. And what about metal imaging? We know that when we look at when we do metal imaging, well, radiographs, they are not bad, but they don't give us as much information as we would want. On the other hand, when we move to CT, then there are metal artifacts. So tomosynthesis can give us more details than the radiograph. And look at the bony trabecula here of this tomosynthesis study. Again, this is taken from a hospital in Japan. It was published in a paper, and you can see that the bony trabecula can be seen here very nicely in the interface of the bone and the metal. But all of this is without getting these artifacts of the CT. So again, what can we see here? We can see some more examples of metal imaging, how we can get in the tomosynthesis more details about this fracture. You can see it much better in this single image. I mean, and obviously it would look even better when we have a whole series of images. And on the CT, we can see the fracture well, but we're getting metal artifacts. And sometimes it's impossible to evaluate whatever's around the metal on CT. And this is an example of loosening, and this is a CT, and this is a tomosynthesis study. We can see that loosening. It's much harder to see the loosening on the radiographs. What about the skull and the bone, the facial bones? So this is an example of a fracture, of an orbital floor fracture. This is the digital tomosynthesis, and when you look at the normal side, we can see that the floor is continuous, but when we look at the abnormal side, well, it's discontinuous here. And we can even see the drop of the contents of the orbit into the sinus. There is also a gas fluid level in the sinus because of the blood. And when you look at the CT, the findings are pretty comparable, because we can see that there is a fracture in the orbital wall, and you can see that same content that is dropping into the sinus. Here we don't see the air gas level, because this was done when the patient maybe was standing, not maybe, the patient was standing, and here the patient was supine. And actually, when we want to evaluate for sinusitis, then here are the sinuses, and it's very hard to see anything here. We don't see a fluid air level, but we also don't see that much that mucosal thickening as we can see it on the digital tomosynthesis. And this is the comparable CT with the exact same thickening and shape as we can see in the tomosynthesis. So it's really comparable. And I think these several examples that I showed you in the last several slides really show you that sometimes it can help eliminate the number of CTs, eliminate the burden on CTs. And it may be very important because remember, I'm sure Michael Hughes told you that that the amount of radiation in CT is in a different order than in tomosynthesis and even more from radiographs. And I actually finished to show you those examples and to cover the most important literature about the applications of tomosynthesis in the MSK system. And I think we're open for questions now.
Thank you so much for your great presentation. I certainly learned a lot, and it looks like tomosynthesis is going to be a really amazing modality over extra